activity jointly sponsored by PVI and the University of Florida College of Medicine.
CM is a 58-year-old woman who has been treated for type 2 diabetes mellitus for 4 years with metformin, 500 milligrams twice daily, and diet. She just moved to the area and hasn't seen a physician for about 6 months, but she notes that she is feeling well. She reports that when she checks her blood glucose level, it is generally about 135 milligrams per deciliter when fasting, and has been as high as 208 milligrams per deciliter at other times of day. She has no history of cardiovascular disease, hypertension, renal disease, or retinopathy. She does not take any other oral medications, but she does take timolol eye drops for glaucoma. She has been overweight for most of her adult life and has a sedentary job. She states that she does not have time to exercise, but that she does a lot of work around the house. She has never smoked. Her sister had a coronary stent placed at the age of 57 years. On physical examination, CM is obese, weighing 212 pounds at 5 feet 7 inches. Her body mass index is 33.3, and her waist circumference is 39 inches. Her blood pressure is 138/84, and her heart rate is 78 beats per minute. No retinal changes are detected during fundoscopic examination. Her carotid upstrokes and auscultation are normal. Her lungs are clear to auscultation, and there are no heart murmurs. Abdominal examination reveals a large pannus, but there is no palpable organ enlargement or tenderness. No edema is detected in her lower legs, and her pedal pulses are normal, as are her deep tendon reflexes. No tendon xanthomas are observed. On the basis of NCEP ATP3 risk categories, what is CM's risk for a CHD event during the next 10 years? The best answer is 3, greater than 20% risk for a CHD event during the next 10 years. The 10-year risk of CHD is high, that is greater than 20%, if a patient has a history of MI, clinically significant myocardial ischemia, or stable or unstable angina, or has undergone a coronary artery procedure such as angioplasty or bypass grafting. In addition, the CHD risk is elevated if a patient has a coronary risk equivalent like CM, who has type 2 diabetes mellitus. Other coronary risk equivalents include non-coronary forms of atherosclerotic disease, including peripheral arterial disease, an abdominal aortic aneurysm, or carotid artery disease. Patients with 2 or more risk factors for coronary heart disease, such as cigarette smoking or a family history of premature CHD, and a 10-year CHD risk greater than 20%, also have a coronary risk equivalent. Diabetes is a particularly important risk equivalent, especially in women, although the disease is often minimized by patients. Yet the risk of non-fatal MI or fatal coronary heart disease in diabetic women is nearly 7 times that in non-diabetic women. Fasting laboratory results reveal elevated total cholesterol, LDL cholesterol, and triglycerides levels. The fasting blood glucose level is also elevated, and the percentage of glycosylated hemoglobin is at the upper limit of normal. A routine urinalysis is normal. However, a 24-hour urine collection reveals the presence of microalbuminuria. Therapeutic lifestyle changes, primarily in the form of dietary changes and regular exercise, are recommended to CM, and a consultation with a nutritionist is arranged. Pioglitazone is added to her diabetes regimen, and ramipril is initiated for blood pressure control and the microalbuminuria. Given CM's CHD risk and specifically the presence of diabetes, what is her LDL cholesterol goal according to the ATP3 recommendations? The best answer is 3, less than 100 milligrams per deciliter. Because CM has a coronary risk equivalent, she is considered at high risk for coronary heart disease. Her LDL cholesterol goal, therefore, is less than 100 milligrams per deciliter, which is generally the LDL cholesterol goal for high-risk patients. However, a subset of high-risk patients, those with CHD and recent acute coronary syndromes, multiple suboptimally controlled risk factors, metabolic syndrome, and/or diabetes, is considered to be very high risk. The ATP3 recommends an LDL cholesterol goal for these patients of less than 70. CM does not qualify for this very high risk category as she does not have a history of CHD. What is CM's non-HDL goal according to the ATP3 recommendations? The best answer is 2, less than 130 milligrams per deciliter. Because CM's triglycerides level is greater than 200 milligrams per deciliter, a secondary non-HDL goal also applies, which should not exceed the corresponding LDL cholesterol goal by 30 milligrams per deciliter, or in CM's case, 130 milligrams per deciliter. The non-HDL cholesterol level is calculated and reported by some laboratories as the total cholesterol level minus the HDL cholesterol level. CM's non-HDL cholesterol level is 224 minus 37, or 187 milligrams per deciliter. Non-HDL cholesterol reflects LDL cholesterol as well as other apolipoprotein B-containing particles such as VLDL, IDL, remnants, and lipoprotein a. Calculating the non-HDL cholesterol level is a way to consider all of these atherogenic particles without determining specific treatment goals for each. In general, the approaches that lower the LDL cholesterol level, such as statins, are effective for lowering the non-HDL cholesterol level. Therapeutic lifestyle changes and improved glycemic control would also likely improve CM's non-HDL cholesterol level. In some cases, specific therapies, such as fibrates, nicotinic acid, or omega-3 oils are necessary to lower VLDL or triglyceride levels. CM met with a nutritionist regarding her diet and began a walking program during her lunch hour. Atorvastatin was initiated after CM was advised of the most common side effects of statin therapy and instructed to promptly report malaise, fever, or muscle pain, tenderness, or weakness. In a diabetic patient with dyslipidemia, what is the expected relative risk reduction of a first-time major coronary event or stroke during the next 4 years with this statin regimen? The best answer is 35%. In the landmark Collaborative Atorvastatin Diabetes Study, or CARDS, atorvastatin 10 milligrams daily was compared with placebo in more than 2,800 patients with type 2 diabetes and one other CHD risk factor, namely hypertension, retinopathy, microalbuminuria, or smoking. This randomized trial was terminated early by the trial's Data Safety Monitoring Board. The average duration of follow-up was just less than 4 years because of a significant 37% relative reduction of first-time major coronary events with atorvastatin. Among the secondary outcomes, the incidence of stroke was reduced by 48%, which was significant, with a p-value of less than 0.001. The baseline LDL-C level was 118 milligrams per deciliter, which fell to 82 milligrams per deciliter with atorvastatin by study end. It is notable that in this study, baseline lipid levels did not predict response to treatment. In other words, the use of atorvastatin was associated with benefit regardless of the lipid profiles among this population. In the randomized heart protection study, a subgroup of 5,963 adults with diabetes received simvastatin 40 milligrams daily or placebo for approximately 5 years. The incidence of a first major coronary event, stroke, or revascularization was reduced by 22% with simvastatin. The baseline LDL cholesterol level was approximately 130 milligrams per deciliter in both treatment groups and decreased to approximately 90 with simvastatin. In 2,912 diabetics without occlusive arterial disease, simvastatin reduced the rates of these events by 33%. The ASPEN trial was a 4-year, double-blind, parallel group study of 2,410 patients with type 2 diabetes who received randomly assigned atorvastatin 10 milligrams daily or placebo. The study was originally intended to be a secondary prevention trial, in other words, to include only patients with CHD complicating their diabetes. However, recruitment of such patients to a placebo-controlled trial was difficult, prompting inclusion of primary prevention subjects with a history of diabetes but no known CHD. By study's end, 1,905 such patients, about 79% of the entire cohort, were enrolled, drastically reducing the study's statistical power because of a much lower event rate in these patients, 10.6% versus 28.5% in those with a history of MI or an interventional procedure. The relative reduction of the mean LDL cholesterol level during 4 years was 29%,